and welcome here live from Munich in Germany, where every day we will tell you all about the best bits of the Transplantation Learning Journey week. And we'll find out all about what that is and what that is all about and what's happening here in Munich very soon. And stay tuned, because we'll also be talking about new tech in transplantation with Professor Nizam Mamode from London in the UK. We'll be talking about robotics in surgery, about printing organs, and all the new and exciting technology stuff that's hitting us. And after that, you will learn all about the young professionals in transplantation, because this show is brought to you by the YPT. And that's why I'm not hosting alone. I'm joined by my two co-hosts, Zeeshan Akta from Oxford in the UK, and Thomas Resch from Innsbruck in Austria. Zeeshan, you're also the current president of the Young Professionals in Transplantation, and you both have been here, are embedded reporters in these two meetings. Welcome.
Thank you very much.
Good afternoon, Gerrit.
Thomas, how are you feeling right now?
Feeling fine, thank you. We've had a very interesting day, a bit exhausted actually, but we've seen so many interesting presentations, and we're keen to tell you about these.
Exactly. And Zeeshan, how are you?
Yeah, really excited. It's been a fantastic day. As you know, this has been a new style of Congress, a new format, and so it's been really exciting to be here, and it's an inaugural version.
Exactly. Let's quickly explain our viewers what this is all about. The Transplantation Learning Journey Week, hashtag TLJ 2018. If you're on Twitter, share your experience right now. Is an initiative to bundle all the different meetings from all the different subsections and committees within ESOT. And throughout the course of 6 days, over 10 meetings take place here in the same venue in the heart of Munich. And that allows those different professionals in transplantation to actually meet up with each other. And today, the first two meetings took place. In this room, we had the ELITA meeting, which is a 1.5-day meeting of the European Liver and Intestine Transplantation Association. That's where you were today, Thomas. And Zeeshan, you went to the EKITA meeting right here next door, which was all about the European Kidney Transplantation Association.
Yes, that's right. But what was fascinating about the meeting is that actually, because of the way it was set up, I could actually go to the ELITA meeting as well and drop into some sessions that I thought were really interesting. So actually, although they are two separate meetings today, we had the option of being able to go between the two, which was great.
So let's dive straight into content and let's dig up some of these best bits. Which one of you would like to start?
Well, I'll start with talking a bit about the EKITA conference, which I mainly attended today. It was a fascinating insight into what's happening in the world of kidney transplantation. We had a really nice introductory talk by Roget Langer about the historical perspective of kidney transplantation, and Thomas is going to showcase some of the slides from that later. We had a fascinating talk from Professor Deertman as well, talking about a number of different factors.
Now, before you're going to list us the whole program, give me the one highlight that you really took away from that meeting.
For me, one of the best bits was talking about robotics in transplantation.
All right.
Because it's very relevant to my career group, I guess. We're very excited about robotics and what it could mean. So that, for me, was one of the big highlights.
Yeah, because you are a surgeon in training, right? And why are you so fascinated by this topic of robotics?
Well, it's cool, isn't it?
Robots are
cool, right? So that's
scary
why
also.
That's why we're fascinated by it. But also, I think for our generation coming through, we're seeing a lot of our consultants, our bosses, working with robots, and we're looking to see, well, is this going to be the technology that we take into the future?
And how do you think it will be applied in the field of transplantation? Where will we see the first robots?
Well, that's a really interesting question, because maybe transplantation may be different to very other forms of surgery, like, for example, colorectal surgery, where there's an emerging body of literature to support its use. And actually, one of the things that we did today during the meeting was actually to do a poll of the transplant professionals to see what they think. Is this going to be a technology that's going to be implemented in 10 years? I don't know if you can show the results.
Yeah, we can show it on the screen. It's your poll on Twitter. And if you're just joining us, we're live, so this is very interactive. Whether you're on YouTube or on Facebook, let us know in the comments right now. Zeeshan is asking you, will robotic kidney transplantation be the main surgical technique for kidney transplantation in 10 years? Well, let's ask your fellow young professional in transplantation. Thomas, where do you stand on that? Agree or disagree?
Absolutely agree. Maybe we can show some historic slides in advance.
Now you're going to make it hard on us. Yes, of course. Let me switch. But tell me, in the meantime, while I look up the slides, tell me, why do you think absolutely yes? on this statement of robotic kidney transplantation?
This technique combines the possibility for young professionals in transplant or for trainees in surgery to train on artificial organs and then go to the patient and train there. This is not possible in conventional surgery, and our guest will show us some of his work about this.
Yeah.
And of course, with advanced techniques, it's always necessary to push techniques even further. And yeah, maybe we can see some.
What do you want to show? And then we'll continue.
Sure. So, I mean, just my opinion on robotics.
Yeah. Zeeshan, where are you? Because we see in your Twitter poll it's a 50-50 divide.
I'm totally opinionated by this because I totally believe that robotics will be the future. Yeah. It was an interesting talk because actually it showed some of the complications that can be associated with early experience in robotics. But of course, that's with early experience. As with any technique like laparoscopic surgery, of course, it goes through a bedding in period. But I'm very excited about the potential that it has, particularly when you combine it with other technologies like machine learning and also advanced imaging techniques that could then be implemented within the theatre as well.
So you're both in the yes camp. Yes, yet we see almost half of your fellow transplantation professionals voting against robotics being the main surgical technique. What are their arguments? What is the main argument against robotics?
Well, the main argument in the Congress was surrounding the complications associated with it, and the real benefit in terms of surgical time, in terms of hospital stay, patient benefit, and also scar size. Is there really a significant benefit? I think for me, having had a little bit of just console experience, no real surgical experience with robotics, I think it's just a very easy technique. I think combined with other technologies, it's going to become incredibly powerful.
All right. Well, let's park this topic for now, and we'll talk further with that with Professor Mamode. So, Thomas, you've looked up the historical slides. Why are these some of the highlights of the meeting here today? What do you want to show us?
Well, I think sometimes if you look into the past, you get some very good answers for today's issues. And I think maybe these historical slides, which were shown by Professor Lange in a very interesting talk about transplant history today, they can help us to answer that question about robotics. Now, here's Emmerich Ullmann, about 100 years ago. He transplanted a kidney. Yeah. And of course, you all know this. This was one week later. The data appeared in the Wiener Klinische Wochenschrift, which was very good journal at this time. Yeah. And these were the problems at that time. Performing a professional suture and a professional anastomosis, this had to be established. And Alexis Carrel, he advanced this technique, and so kidney transplantation became reality. Now, this is still difficult. We all have to train this and learn this. Yeah. And maybe this is going to be the future, how this is going to look next. Before you just go through the slide deck, so how does this history lesson then teaches us something about the opportunities of robotics in surgery? Exactly. We all have to learn this. This is not easy doing this. So it always has to be the first patient when you do this, when you have to practice this. But maybe this doesn't have to be the case. These are pictures from a publication of the group from our guest, Professor Mamode. And they showed in this publication, they show a robotic device in the right picture. Yeah. You can. This is a fully functional robotic device where you can operate people and transplant kidneys with. And in the left picture, you see a printed organ. So trainees can study this, can train the techniques, and still the anastomosis is quite challenging. And in robotics, this allows you to do this in a practical training first, before you go into before you actually see a patient. And so this is one of the big advantages, of course.
Exactly. Well, I
But
feel
Professor
that we
Mamode will
almost
tell us later
should
about
invite
this.
him now, because we keep looking at him, and he's there in a minute. Before we do that, can you give me one key highlight that you took away from this ELITA meeting about the liver and intestine transplantation here today?
Yes, of course. As you can see, we've taken so many notes today, so many interesting sessions.
Before
but
the show, you said I have about 50 things I want to show.
Exactly. We have to cut it down. The ELITA meeting began with liver transplant for metabolic diseases, and I want to pick one out which was particularly interesting. This was Professor René Adam, who gave a very interesting talk about these rare diseases. Could we see the slide?
Yeah, it's coming. Yeah.
Perfect. So you see, these diseases make only up about 6% of our recipients, 5% in adults, and about 1/3 in pediatric recipients. Now, it is very hard to study these rare diseases, of course. So what they did is they addressed the ELTR database, which is a very renowned and very good registry. And what they saw is that most of these patients transplanted for these rare diseases, the outcomes were excellent. You see here, except for the hemochromatosis patients, all of these recipients with metabolic diseases, be it Wilson's, be it alpha-1 antitrypsin deficiency, be it NASH, be it FAP, these patients did very well afterwards. And this is the overall ELTR survival, which is excellent, which 75% after 5 years, about roughly. And most of these recipients did even better.
So Thomas, tell me, why do these data excite you? Why is this important for all transplantation professionals to know about this?
Well, it encourages you in two ways, actually. One, it encourages us to perform liver transplant in such patients. And second, it shows us that, particularly in rare diseases, we have to rely on good databases and feed these with good data. And in one subsequent oral presentation by Jean-Charles Duclos-Vallée, he looked at the patients with Wilson's disease. I showed you the graph. This is about 22% of the patients with metabolic disease of the recipients, and he wanted to know, how's the outcome in function? Mm-hmm. Do these people not only live, but do they improve? How about their neurological signs? Yeah. And maybe we can have a look at the slide again. I'd like to show you two of the slides I nicked from him.
Yeah, because that's for the people who are just joining us. You go and search the slide. I'll tell them quickly. What you've been doing, you've been actually going up to speakers and say, hey, can I have slide so-and-so to actually show to our viewers right now, right? So have you shown us what you wanted to show? Is there one more? They
gathered the data from Wilson's disease patients, and again they joined up multiple centers in France. You can only do such a study in a multi-centric approach, and they gathered data from 22 Wilson's disease patients, and again you see very good survival rates. But what really impressed me is these are the neurological improvements after liver transplantations, the neurological signs and symptoms. And as you can see, can we have the slide again? Yeah, perfect. Most of the green line says most of them improved a lot, about 80%, and the others at least moderately or mild improvements. So very encouraging data there.
Yeah, so you say key takeaway is we now have a new application for liver transplantation because we actually can cure rare diseases, and we weren't that aware of that it was such a good solution.
And bundle the data up, work together, multicentric approach.
Good.
Not to keep the data, everyone on his own, but share these.
All right. Well, talking about sharing, I think thank you for bringing this best bit of the ELITA meeting here today with us. Thank you for sharing the excitement about robotics. I think we need to move on to the most exciting live and interactive bit of this little live show. If you're just joining us, you can either on Facebook or YouTube use the comment field and type in your questions, because I'm going to now get off stage, My seat is going to be taken by Professor Nizam Mamode. We're going to talk all about the latest and the greatest in new technology in transportation. And if you send in a question, I'll jump in with Zeeshan and Thomas and ask your question on your behalf. So, Nizam, please join me. Here's the mic.
Thanks very much.
Thank you for joining us on stage. It was a real pleasure to listen to your talk today. I think we've both got a number of questions that we'd like to start with, but given that we were talking about robotics and you have actual hands-on experience with the robotics, I wanted to get your opinion on what you think about that field and particularly its application within kidney transplantation.
Yeah, I mean, I think the discussion on robotics for me was the best part of today. And I have to say that I think that the likelihood is in 5 to 10 years, we're going to be doing most, if not all, of our transplants robotically. At the moment, when we think about what that means, it means a big, expensive system, costs about $1.5 million. The consumables are very expensive. It's a bulky system. It doesn't have haptic feedback. And we've got an operation that actually has excellent results. The open operation, we know, has a very, very good success rate for living donors. So when you put all those things together, you may think, well, is it really worth it? But when I think back to 2002, 2003, people were saying the same things about laparoscopic donors. And it was very similar in terms of the operation. We did open donor operations where we did a large muscle cutting incision. We replaced it with a small muscle splitting incision. And donors changed from going home after a week to going home after 2 or 3 days. But at the time that we started it, I was one of many, many different people who started it. People were saying, this is a waste of time, it's expensive, it's unnecessary, why bother doing this? And I think the likelihood for me is that we're going to go down the same path with robotics, and it's going to become the way to do it.
So you voted in the poll to see robotics in 10 years' time. You're in the yes group, were you?
Yes, absolutely. And I think one of the things that we need to realize is that things are changing in the fields of robotics quite dramatically. The company that has the patent on the Da Vinci robot has dominated the field for many years. We're now seeing new robots coming in. There's a robot coming online literally any day now from Cambridge Medical Robotics, which may have some features which are potentially better. It's likely to be significantly cheaper. There are other robots coming through from Medtronic, Google, and so on. And I think we're suddenly going to see simpler systems, less bulky, less cumbersome, cheaper, with the feedback, which make them easier to use, and they will replace laparoscopy throughout surgery, in my view.
Well, I'm totally in your camp. I totally agree with that. But I just wanted to ask you about one thing that you said in the conference, which was about the need for a randomized trial to demonstrate benefits of robotics over presumably laparoscopic. Do you think that's what's going to be necessary to prove that robotics is the future? Yes.
I mean, I think when we look at laparoscopic donors, there were 3 or 4 randomized trials done, most of them relatively small numbers. They provided some evidence, but they were never really that conclusive in my view. Similarly, when you look at the use of robotic surgery in urology over the last 5 to 10 years, there've been a few trials. Some of them have shown no benefit. Some of them have shown some benefit. But there are a large number of procedures where there haven't been any randomized trials, but it's become standard of care. And that's what the patients want. That's what the surgeons want to use. I think what we're going to have to do is pick a point, and it's going to be a very critical point, where we have enough experience to have got through our learning curve, and then we institute a randomized control trial of robotic versus open surgery for implantation to determine whether or not, in fact, it is beneficial. And benefit is not just in terms of patient recovery and length of stay. We also need to look at things like rejection, for example, because it may well be the case that a longer warm ischemic time leads to more inflammation, leads to more rejection, acute or chronic, subsequently. Or it may be the case that with a lower systemic response, we see less of that. We don't really know. Personally, I think it won't make much difference, and I don't think the warm time is that important if it's 50 minutes to an hour, I don't think that matters that much.
Great. Well, I definitely agree a lot with what you said. I think certainly for me, it makes sense for there to be a safety trial to show there is safety. But one of the things I really struggle conceptually with understanding is with something like robotics, which is advancing at lightning speed at the moment in terms of development, how can there ever really be a fair comparison between two techniques, one which is well established and one which is kind of in the acceleration phase of development? And secondly, you know, as you kind of alluded to, the outcomes of living donor kidney transplantation as well, are very good, and therefore the power that we would need to achieve in order to demonstrate a difference would be significant. And that makes me think, actually, whether a trial is actually really feasible, comparing the two technologies. Thomas, what do you think?
I've actually got one other question. I'm sorry.
No, it's a difficult question. I'm sorry to throw that to you.
I was thinking about my next question. I was listening to you. I'm very sorry, see. So, Professor Mamode, you recently published an article in Annals of Surgery on patient-specific 3D printing, a novel application to enhance preoperative planning in complex living donor pediatric renal transplantation. I've shown one of the models before in the slide. Can you tell us a bit about this?
Okay, so maybe just before I do that, I'll just go back to your question in terms of a randomized trial. Again, I see a lot of parallels with the laparoscopic donor surgery. So the first question that we had there was, is a laparoscopic approach safe, and is it better for the patient than an open approach? And then subsequently, we've gone on to have a series of trials to say, well, should we go retroperitoneal or intraperitoneal? Should we have a hand-assisted or a pure lap, and so on? And I would see the same process with robotic transplantation. The first question will be, given the current technology and using people who are experienced at that, can we show any benefit over open, and can we show that it's safe? If we can't, then we stop. If we can, then subsequently we go on to say, well, is the new system with haptic feedback better than the old system without, and so on. So going back to your question, Thomas, in terms of 3D printing, so we've used this in a couple of ways. One way, maybe before I come on to the pediatrics, is on the robotic theme, and the slides that you showed earlier on. We've used it to develop a trainer for the robot. And one of the difficulties if you're trying to do robotic transplantation is that for many transplant surgeons, if they're not urologists, they won't have had significant experience on the robot. And even if they are urologists, they may or may not have had significant experience of suturing. And suturing a renal vein is pretty difficult without haptic feedback. So in my experience, it's quite hard actually to use the robot to do those vascular anastomoses. People often say, oh, it's easy, it's better than laparoscopic surgery. Certainly easier than trying to suture laparoscopically, but compared with open surgery, it's a very different skill that you have to learn. And I would make a guess of around 60 to 70 hours on the simulator. So that's on the simulator, on the robot, on the machine. Once you achieve good scores on the simulator, then the next step is normally to go on to stitching bits of glove together and so on. But actually that's quite easy to do because you're not constrained by certain angles, and you don't really get a feel for what the vessels are like. So what we did was we 3D printed an abdomen, and we 3D printed a kidney, and we left a space in the iliac vessels, the iliac vein and artery, and we shortened the renal vessels. And then we use deceased donor vessels, spare vessels that we've got permission to use, and we tie those in and then do the anastomosis robotically. And actually I find that gives a very, very realistic simulation of what's needed. And I normally have 1 or 2 goes on that before I do a robotic transplant.
Even you, as as a full professional?
Yes, I'm very early on in my learning curve, and we've got good data from the lap donors that it's about 35, 40 cases for laparoscopic donor nephrectomy to get through your learning curve. I would suspect that for robotic implants, it's probably going to be higher than that. It's probably going to be nearer 50 to feel really comfortable. We know we've got a close relationship with Pranjal Modi in India, who's done the most in the world, about 300 now probably. And it took him a long time to really feel comfortable with all the things that can go wrong. One of the things that you need to think about if you're using new technology, and we saw this happen in India, is the computer can just fail. So we've all had experience of our laptop freezing and we hit it and throw it on the floor and stamp on it. But if you're in a situation where you have the needle going through the renal artery and the iliac artery, your suture is in there, the kidney's in, warming up, and the screen freezes and you press the reset button and nothing happens, then you're in big trouble because you can't just pull the instruments out. Your kidney's getting warm, you've got to do something. And I've seen that happen. So knowing how to deal with some of those problems, as well as the simple technical aspects of suturing are really, really important. And the non-technical issues, if you like, or the side technical issues are very different from open surgery.
Hopefully you have time for this. In terms of warming up, which is what you were describing, getting onto the console, having a few goes before you actually start to operate. Have you noticed anecdotally any difference in your operative performance if you do that? Because that's a very interesting phenomenon.
Yes, definitely. Yeah, I mean, it's like anything. If it's the 10,000 hours approach. The more you do, the easier it becomes. And I think what we tend to do when we start on the robot is we listen to the company's hype, which is, anyone who can do open surgery can use the robot. It's no problem at all. But actually, you've just got to learn a few things about how you deal with the angles, how you don't wind up the instrument, how you position your hands, how you sit. Ergonomically, you need to make sure that you're sitting in a comfortable position, and it takes a while for you to realize what that is. How you move the camera constantly. That's something that it took me a while to learn. So when you watch very experienced robotic surgeons, they're constantly making little movements of the camera. And when you use the robot, what you have to do is press a switch with your foot to switch your hand control from the instrument to the camera, and then press it again to switch back. And experienced surgeons will do that unconsciously, constantly. So if you think about a lap donor, with your good assistants, they're constantly moving the camera around before you've even asked them, and you don't have to think about it. If you're thinking about, while you're doing a robotic implant, you're thinking, I need to move the camera, and then making a conscious effort, that's taking away cognitive function from doing the operation. And so what people tend to do is not move the camera. Sure. They just leave the camera in the same place, and they focus on the stitching, and they don't get a very good view. So these little things you learn by just practicing and practicing and doing it again and again.
And one final thing on that topic. Do you think that will increase the longevity of surgeons? As in, do you think robotics will enable us to actually be surgeons for longer in our careers? Because, actually maybe it's more comfortable operating. Maybe we can operate for longer periods of time in a console than we can at the side of the patient.
Yeah, I mean, obviously at the start of a program, it's very stressful compared with the open operation. But I think already it's certainly clear to me that the ability to get up, have a stretch, just walk around for 5 minutes and then sit back down without having to scrub and unscrub actually makes a big difference. We're a big believer in human factors in our department. If we have a long, difficult open operation, we go off and have a coffee and we take a 15-minute break and come back. You can do that frequently with little breaks during the robotic procedure at the appropriate times. So certainly I think as systems improve, it's likely that we will find that it's physically less stressful.
I have one more question, but do I have time? So, are you worried that someday there's going to be a computer running the console, and it's not going to be a surgeon there? Is that something you've thought about?
I wouldn't be worried about it. I'd be quite happy with it, actually. I think machine learning is one of the other big innovations that's going to come in the next 10 years, and we're going to see it in transplantation. We already have robots that are autonomous or semi-autonomous. So you can program a robot to drill into your head, find the tumor, and deliver whatever therapy you want to that intracranial cancer. We're obviously a way away from having a machine stitch an artery, but actually if you think about a lot of things that we do in surgery, next time you watch someone take a knife and cut through the skin and go through the layers into the abdomen, think about how inefficiently we do it, all of us, however experienced we are. We make a cut, we stop, we diathermy the vessels, then we cut a little bit more, then we stop and diathermy again. We already have the technology to make a cut, to scan for vessels, to diathermy them preemptively, and to keep cutting, and to do those iterations thousands of times a second. So to make the cut quicker, to make it with less trauma, with less bleeding, we can do that already with existing technology. Those systems, I think, are likely to come in. The difficult bit is the decision-making around more complex actions. But I think, again, if you think of things like driverless cars, if we can have a car driving along the street, we can have a robot doing surgery, in my view.
Brilliant. Well, do you have any further questions, Thomas?
Very impressive, yeah.
Okay. Well, thank you. Should we switch back? Thank you. That's great.
Give him a big round of applause. Yes. All right, thank you. Thank you, Professor Nizam Mamode. And thank you for joining us live here from Munich. If you're just tuning in, we're talking about the best bits of the Transplantation Learning Journey. And I just want to make a few shout-outs to some live responses we have from viewers. Obviously, we're on Facebook and we're on YouTube. We're talking about very surgical, practical stuff that is interesting for the transplantation community. But if we go public in this domain, we might hit patients. So here's a viewer from Belgium, Maria de Witte, who's saying, I'm watching from Antwerp in Belgium. Thank you very much. I was transplanted at the Royal Free in London in 2007 already, doing very well at the moment. Extremely thankful to all the staff and my donor. And I think, as I'm not from the transplantation field, I always find it very touching that you guys, however I can be busy with live streaming and online content, you guys are actually saving lives and making an impact on people. It's powerful. How does that make you feel as a young professional?
Thank you very much, Maria. This, I think, gives us a great motivation. Come together, discuss about new technologies. Thank you, Maria. This was very nice. Yeah, because Zeeshan, we talk about all this robotics and high-tech stuff. What is actually your key driver to be in the field of transplantation?
Well, yeah, I mean, clearly it's for patients, you know. I mean, I think for anybody who's in transplantation, one of the key satisfying features has to be when someone gets a functioning organ and they can, you know, stop dialysis, they can go back home. That's what it's all about, you know. It's an incredible experience to feel like you've been able to help somebody in that way. I think that's why the majority of people, including in this room, are probably involved in transplantation.
Exactly. Well, and talking about patients, we're also being joined live and followed by the PSC Patients Europe. And I had to look that up, PSC, just to double check. But that's the European Primary Sclerosing Cholangitis Community. And I think they have a question for you, Thomas, because you were in the liver meeting all day. And they wonder, have you heard anything about PSC? You started talking about rare diseases and how liver transplantation can be a cure for that. And especially, is there any data or best practices on pregnancies and births after liver transplantation? Have you heard anything about that here today?
I'm not particularly on PSC, I'm afraid. But
so the short answer is no. And now you're going to give a long answer.
Short answer is no.
Yeah, it wasn't discussed here today. That's what this show is all about. But what can you say to them? Is there anything to say?
Well, there's obviously for that specific patient, I mean, they would need to get in touch with a local hepatologist. They'll be able to provide the most regionally appropriate advice. today's just been half a meeting today, so it's very short, so we haven't covered all the topics.
No, exactly.
So it may be brought up later on, but I would definitely advise if any specific questions, specifically regarding pregnancy following transplantation, to really speak to your local hepatologist.
Yeah, of course. And I think for them, they do that on a daily basis, they say. It's live, we see your comments coming in.
We've got till the program tomorrow, though, so don't worry, we will discuss this topic in particular.
Okay. So if people are just joining, we're here daily at 6:30 talking about the best bits. So perhaps you find more about that.
Yeah, please watch the show tomorrow. You will find some answer there, maybe.
Well, and if they are live, let's take the other questions. So what innovative ideas have you heard, either here in the meeting or in general and as a professional, to shorten those waiting lists? What do you think are some of the promising developments there?
Well, I mean, that's a $1 million question, isn't it?
Yeah, I know, but let's explore
you're
it a
trying
bit.
to answer a really difficult question, because I mean that's what a lot of the talks within the kidney symposium today was really about. Was about how can you address that shortage. I think one of the key technological advancements that's likely to change that is machine perfusion of organs, basically.
All right.
So these are when, for people at home, this is when an organ's taken out and is put on a machine and it can be perfused. And we had some really nice talks today from Anna-Marie Weissenbacher, who's formerly from Oxford, now is at Innsbruck.
And who is with us in the room.
She's with us in the room.
Anna-Marie. Good to have you with
she gave
us.
us fascinating insight into machine perfusion of the kidney, and gave us a historical perspective on perfusing kidneys at cold temperatures.
Yeah.
Well, I say historical, actually, that's not that long ago. That was only discovered about in 2009, 2010. But she started to talk about her own research in normothermic machine perfusion. What that really means is, of course, perfusing at normal body temperatures. And some of the work that's coming out from her PhD, but also some of the work that's been done in Cambridge by the Nicholson group as well. And she gave a very nice outline. And for me, that could be a game changer, because suddenly you can assess these organs that you're not sure about whether you should transplant. You can do viability assessment, and so for me that's one of the key areas that we'll be probably looking for in the future to try and help. Yeah,
because in layman's words, that technology might actually provide more potential donor organs to actually make it to recipients, right? That's what that technology does.
Right, we discard a lot of organs because we're not sure about their quality, but suddenly if you've got a system that you can use to assess quality, then that could be a game changer.
Yeah. Thomas, anything to add?
Yeah, maybe we can show. I enjoyed one more oral today very much, the one by Daniel Azoulay.
You want to show another slide?
Maybe we can show another slide.
All right, cool. Let me hit them up. And what did you learn?
Because this was in the session regarding the difficult recipients, and what was quite surprising for me was.
Is it this one?
Exactly.
It's this one.
Perfect. Thank you, Gerrit. We were talking about the difficult recipients, and obese recipients are amongst them. Now, what he was pointing out is that in the US, more than 50% of the recipients are overweight, and this is going to be more. And this problem is coming to us as well, affecting the whole world and Europe as well, more and more. And what he pointed out is that in normal or in other surgical patients, obese patients, we see what he calls the obesity paradox. These patients recover very well after surgery. We don't know really why, but they're doing very well.
Medical
afterwards.
mystery, yeah.
But in liver transplant, this is not the case. We're missing this obesity paradox. And he gave an explanation for this, and probably this is because of a concomitant sarcopenia. Now, this was underlined by another talk by Giacomo Germani today, who said that the meaning of sarcopenia has been underestimated. This is very important. These people tend to get more infections afterwards. The hospital stay is longer, and mortality is increased. So we have to look for this.
And Thomas, how can you use this new insight in your personal work, either as an academic, in your research, or in your work in clinic?
Yeah, we have to look for factors in the recipients which we haven't looked for in the past. Again, Giacomo Germani pointed out that psychiatric diseases, like a simple embraces depression, even has a strong impact on hospital stays and even on graft survival. These are all new data, and this is very interesting. And also, what he pointed out is that maybe old facts or old meanings or paradigms are maybe not true anymore in our recipients, like diabetes. He showed us data that the diabetic recipient might not even be off worse than the non-diabetic recipient. There are studies showing worse survival, there are studies showing equal survival, and there are even studies showing a better survival in patients with diabetes. So we have to rethink many of these old paradigms. And this session here at the TLJ was very interesting in this regard, and this was.
But to tie this into the previous question about innovative ways to shorten the waiting list, doesn't this mean that more patients become, or more potential recipients become eligible, so the problem actually becomes worse?
Yeah, exactly. And I think I
see that as a win.
You see that as a win? Please explain.
Because if you've got more people who are becoming eligible for transplants, that means
that's a win.
That's a win
because we can cure
because
more patients.
We're getting better.
We just have to solve where we print the organs or where
so
we get
have
them
to
from.
Look at,
And as we've learned from Manuria today, maybe with normothermic machine perfusion, we've got the answer there. We will have more organs available.
Exactly. Now, and if you're curious to learn all about machine perfusion, that's obviously a hot topic here at the Transplantation Learning Journey Week. You will be back with me on Friday, right? And we'll be talking to Beatriz Dominguez-Gill, and specifically about what's new in machine perfusion. So mark your calendar, Friday night, have a drink with us, and we'll talk about what's new in machine perfusion. So to wrap up this first best bits, let's explore a bit. This is organized by the YPT, the Young Professionals in Transplantation. The average age in the room here is definitely under 40. So to people who are new, what is the Young Professional Transplantation Network? What does that do?
So it's a part of the society that was set up to foster people who are kind of in their careers, building their careers in transplantation. They're obviously not the level of Professor Mamode, but actually trying to build careers so that they can be like him, be like others who've presented today. And we're just trying to foster innovation, foster networking and career opportunities.
And what does that look like? Say I want to become a member. First I join ESOT, and then I sign up for the YPT. And then what? How does the network materialize for you personally, Thomas?
Well, basically it's sign up ESOT, tick the box YPT, that's the easy bit. And then we're about, with a little program, little project, we're trying to tie those young professionals all over Europe and all over the world more together. We're establishing a little map where you can be on. I go over this map of Europe, and then I go to Innsbruck, and then I find myself, and I can contact this person. And same here with C and many others.
So that makes it easy to actually visualize and see where other transplantation professionals are active.
I don't want to say too much. We're launching this project right now, and Jeff LaFranca is going to tell you a lot more about this on Wednesday. But C, could you tell us a little more about the YPT workshop?
Yeah, so on Thursday we are, just a plug for ourselves, on Thursday morning we are doing a workshop on tech and innovation. And
you mean we're doing a workshop right here in Munich, right? So if you are anywhere within a 500-kilometer radius of Munich, you can still clear your agenda for Thursday and get here, right?
Yes, you can.
Okay, let's be clear on that.
And it's what we're trying to do is foster innovation amongst youngsters, because today we have so much power available to us. Our phones have processing powers that we could never imagine that we would have, right? And actually, the tools that are available to us youngsters, or anyone, you have to be young to do it.
Yeah, exactly. They're available to all of us, but we use them a bit more,
But coding and machine learning and big data technologies are there, and they're often open source. So if you've got an idea, you can begin to implement and begin to make real change, and that's the type of culture that we want to foster. And so we're going to be doing a workshop on Thursday to talk a bit about how you can do that and tell people about some projects that have got off the ground in technology and enterprise, so that people can kind of find out about that.
And what do you hope they take away from that? How does that change their life next week? What can they do with that?
Well, hopefully they'll start working on a number of projects that will really make changes to their transplant centres. That's the aim, is to foster this so they can begin to address clinical issues for their patients and for their transplant centres to make them more effective and begin to introduce technology into them in a way that perhaps we often forget about, actually.
Exactly. Well, sounds very exciting. And can you highlight some of the other activities that the YPT is conducting? How else are you consuming the YPT network, Thomas?
Well, we're working on a financial project which Sushma is going to introduce. Is Sushma going?
That's right, yeah.
Tomorrow?
So tomorrow we have somebody who's going. I don't want to steal her thunder because...
We'll just make an announcement so people join in again tomorrow and learn all about that.
All I can say is that she's doing an incredible project looking at trying to improve access to transplant training and education within transplant centres with very low transplant activities. So what that really means is that she's trying to make a project with Hannah to try and promote transplantation in countries that don't have that much transplantation.
Exactly. So in essence, the YPT is all about the network, stimulating education, and being more innovative and entrepreneurial within the transplantation fields.
Precisely.
Well, and I think this is proof of that, and you're proof of being a part of that. Thank you for watching all the way to the end. If you know anybody who might find this interesting, either some of the stuff that Professor Mamode was talking about in robotics in surgery and all the innovative stuff coming towards us, or specifically about if you know any young transplantation professionals, make sure you hit the share button right now and share this video either on YouTube, Facebook, email, WhatsApp, whatever you have at your disposal. Or if you're on Twitter, use hashtag TLJ2018 and we'll be searching for that and we'll see you, we'll be interacting. With that, I would like to thank you very much, my dear co-host. Thank you very much for being our reporters here and scouting the best bits. Thank you very much for joining us, and we hope to see you back tomorrow, same time, same place, here live from Munich.